Welcome back to Alterations in Digestive Function. Let's pick up where we left off here. We were talking about liver dysfunction, so let's take a look at some questions relating to that. The most common disorder associated with upper GI bleeding is esophageal varices is the most common disorder associated with upper GI bleeding. Okay, now keep in mind again, we're talking about the most common liver disorder here that's associated with upper GI bleeding. We can have esophageal varices only accounts for about 14% of all upper GI bleeding. Again, we're going back to what's happening here with gastric or peptic ulcer disease and our patient who is taking nonsteroidal anti-inflammatories and has H. pylori as being the most common situation that occurs with upper GI bleeding in general. We're just talking here more specifically about liver dysfunction. A 16-year-old female presents with abdominal pain in the right lower quadrant. Physical examination reveals rebound tenderness and a low-grade fever. A possible diagnosis would be appendicitis is manifested by right lower abdominal pain with rebound tenderness, and that's a very classic of appendicitis. Colon cancer usually is going to be asymptomatic. It's followed by bleeding. In other words, the first symptom we often see of colon cancer is bleeding. Pancreatitis usually is either manifested by vomiting or by having upper abdominal pain. Hepatitis would be upper abdominal pain as well. Hepatic encephalopathy is a condition where the patient has increased ammonia levels in the blood, and this is the result of incomplete or ineffective protein metabolism by the liver. The liver is not metabolizing protein. Protein is starting to back up in the body and is starting to build up. Although ammonia can have effects on many parts in the body, the part we're going to see it the most dramatically is going to be on the central nervous system, where the patient's going to have changes in their central nervous system function. These are primarily due to the development of cerebral edema as a result of having these increased ammonia levels. Jaundice can be described as being one of two different types. It can be obstructive in nature, where bile, conjugated bilirubin, can't get out into the duodenum, and so we're having an obstructive type of jaundice where bile is backing up into the liver. Or we can have a hemolytic type where we're starting to break down red blood cells, and that's causing the patient to have jaundice. This is a picture here of a person who has jaundice. You see the very yellow part of the eye. Jaundice is not an early sign of liver disease. It's a very late sign of liver disease. Okay, so this isn't something we want to sit around and wait for and say, oh, let's just wait till the patient has jaundice. Okay, it's a late sign of liver disease. Now remember, the liver is very redundant. We need to have lots of redundant liver function because if the liver fails, we're just out of luck. There's nothing to take the place of it. So we need to have lots of redundant liver function. If we're seeing jaundice, that means we're at the point now where the liver is no longer able to compensate for the dysfunction that is occurring. A 54-year-old male complains that he has been vomiting blood. Tests reveal portal hypertension. Which of the following is the most likely cause of his condition? Portal hypertension occurs secondarily to cirrhosis of the liver, not thrombosis of the spleen or ventricular failure or renal stenosis. The most common clinical manifestation of portal hypertension is blank bleeding. Esophageal bleeding, esophageal varices, most common cause of the person having Vomiting of blood from the bleeding esophageal varices, most common clinical manifestation of portal hypertension. So most of the time we don't know until we see esophageal variceal bleeding or until we start to see the development of ascites. Hepatitis. Hepatitis is a viral infection of the liver. Now, this can come in a number of different forms. You hear these different terms: hepatitis A, hepatitis B, hepatitis C. There's actually a D and an E. Maybe there's even more that we don't quite know about yet. But hepatitis A is the type of hepatitis that can be transmitted from person to person. It's an oral fecal transmission. So we're transmitting it because we're not washing our hands after we go to the bathroom. And you get this from that oral fecal route, and then the patient develops a dysfunction of the liver. So it's an infection, a viral infection of the liver. And hepatitis A is usually going to be pretty self-limiting. We may end up having some liver dysfunction as a result of it, but it usually is fairly self-limiting and we usually resolve on its own. There is no treatment for hepatitis. Remember, these are viral infections. There is no cure for a virus. The only thing we can do with viruses is we can try to decrease the amount of viral load there is by giving an antiviral. So antivirals are not like antibacterials. They don't kill bacteria, like antibacterials would. They decrease the viral load rather than killing the virus. So then another type would be hepatitis B. Hepatitis B is going to be contracted from infected blood or body fluids and contaminated needles. This is probably the most important reason why you're going to use universal precautions with your patients. So we're going to wear gloves, we're going to wear masks and gowns when it's appropriate with our patients because we want to try to prevent the getting hepatitis B, because hepatitis B is spread by body fluids, and we don't want to get those body fluids to touch an open part of our body where then they can enter our body. Hepatitis C. This is a situation where the patient is going to probably, in most cases, develop chronic hepatitis. Hepatitis C is the most common reason for people to have to need a liver transplant. Again, this is going to be a blood-borne, body fluid-borne type of infection. So clinical manifestations of bile salt deficiencies are related to poor absorption of clinical manifestations of bile salt deficiency are related to the poor intestinal absorption of fat and fat-soluble vitamins. Manifestations associated with hepatic encephalopathy from chronic liver disease are the result of impaired ammonia metabolism leads to the symptoms that we see of hepatic encephalopathy. So it's this buildup of ammonia in the bloodstream that's causing the person to have hepatic encephalopathy, which is going to be a change in mental status as a result of not being able to metabolize ammonia. An increase in the rate of red blood cell breakdown causes which form of jaundice? That would be hemolytic. So excessive hemolysis of red blood cells can cause hemolytic type of jaundice. So cirrhosis is the situation where we have an irreversible inflammatory disease that disrupts the liver function and structure. So we're not only disrupting the function, we're also disrupting the structure of the liver. So the structure of the liver becomes altered because fat is starting to build up and the entire the entire liver is starting to change, not only in its function but also in its structure. And this is going to start to cause, as it says, biliary channels become obstructed, causing portal hypertension. Blood shunted away from the liver is then going to cause hypoxic necrosis of the liver, which then further worsens the cirrhosis. Cirrhosis can be caused by too much alcohol ingestion. Okay, so alcohol is basically a poison that we're putting in our body, and the liver can handle small amounts of poison, but we put too much poison into the body, it ends up causing damage to the liver. We can also have bile stones blocking the bile duct, causing bile to back up into the liver and initiating the cirrhotic process. So this very busy diagram here is illustrating what happens when a patient has liver inflammation, liver necrosis, and finally liver fibrosis and scarring, the end results of having liver necrosis. So liver inflammation over on the left-hand side, pain, fever, nausea, vomiting, anorexia, fatigue. Okay, so that's just the inflammation part. This can happen with patients who have mononucleosis. They can have inflammation in the liver as a result of that disease process. That doesn't mean the patient's going to develop ascites and portal hypertension, all that other kind of stuff. However, if the liver disease goes on long enough, say for example from hepatitis C, then the patient starts to develop liver necrosis. Here's where we start getting into all of those different problems. Bilirubin metabolism starts to become involved, gastrointestinal tract starts to become, we start to have alterations in our GI function because we don't have enough bile getting into the stool. Decreased vitamin K absorption, which is going to lead to bleeding tendencies. So you see multiple problems resulting as a result of liver necrosis, leading down here to liver failure. The liver starts to fail. That is also going to start to cause the renal system, the kidneys, to fail. We get hepatic encephalopathy, hepatic coma, and death. Okay, so this is a big deal. What we do to deal with this is if a patient has liver failure, we have to just deal with the hepatic encephalopathy by trying to control the ammonia level, try and control the patient's protein intake, and try and decrease the amount of intracranial pressure there is until the patient can get a liver transplant. When we're that far down the road here, there really is no chance of being able to back up and restore that liver function. So we need to catch this early on. We need to be finding the problems early on and hopefully avoiding, at least as much as possible, avoiding those life situations that can lead to liver dysfunction, like excessive alcohol use. The icteric phase of hepatitis is characterized by which of the following clinical manifestations? The icteric phase is manifested by jaundice. Dark urine, clay-colored stools, the liver is enlarged, smooth and tender, percussion causes pain. This is the actual phase of the illness. In other words, this is where we're seeing really profound liver dysfunction. Remember again, that we're not seeing symptoms until the liver gets pretty far down the path because it has a lot of redundancy. It can continue to work even though a lot of the liver has still been damaged. Disorders of the gallbladder. Cholecystitis is an inflammation of the gallbladder. This is very common, and there's some certain things we can look at to help us to tell us who is going to have cholelithiasis, which is the gallstone formation as a result of cholecystitis. So this is kind of like the chicken and the egg. What happens first? Did the gallbladder become inflamed, causing the person to develop gallstones, or did the gallstones form, causing inflammation of the gallbladder? But cholecystitis is the inflammation of the gallbladder. The actual stone formation is called cholelithiasis. These stones form because of a cholesterol base. So there's cholesterol underlying this base of the stone that forms. So other chemicals, other substances, probably calcium, etc., forms around that cholesterol, but cholesterol is the underlying form of this thing. Okay, now understand what we're going to take a look at this gallbladder here in just a minute. Risk factors. A number of different risk factors. You can look at the ones listed in your book. The way that most people were taught about these is the F's. The 4 F's. The risk for having gallstone formation is that the patient is 40 or older, fair, fat, and fertile. Okay, so let's talk about what that means. 40. It means at the age of 40 or greater, more people have gallbladder disease than at younger ages. Certainly, there's a lot of people who have gallstone disease at younger ages. We've noticed recently that there's been an increase in the number of people who have gallstone disease after having a baby. Fair. So usually lighter skinned people have a greater chance of having gallstone disease. Fat. So the higher our diet is in fat, the greater the risk of having gallstone disease. And then fertile. So still we had not having gone through menopause. So let's take a look at the anatomy here for a moment, and you see that the liver is up there at the top. We can't see it, so we're coming down from the liver through the common bile duct there, and then branching off to the left, we have our gallbladder. So our gallbladder is sitting there. Now the purpose of the gallbladder is just kind of this hollow muscular sac, and it sits there and it collects bile. So bile is being produced all the time from the liver, comes down, it drips down into the gallbladder, and it sits there in the gallbladder. Now, when we need bile for digestion, then the gallbladder contracts and squeezes bile out into the duodenum. However, we don't need bile all the time, so that's just happening on an intermittent basis. So there is a bunch of bile that is sitting in that gallbladder at any particular time. Now, have you ever had one of those days when you came into work and you poured yourself a cup of coffee and you didn't touch that cup of coffee again until the end of the day? You come back after 12 hours and you pour out that cup of coffee. What's down in the bottom of that cup? A bunch of sludge, right? Okay, so you're seeing all this junk down in the bottom of the coffee cup, and that is the coffee that is just kind of settled down into the bottom of that cup by the end of the day. Well, the same thing happens in the gallbladder, in that this bile will start to settle out over time. That's why the older the patient is, the greater the risk the patient's going to have stones. Theoretically, we would say the more stones the patient has and the bigger the stones are, the greater the risk the patient's going to have symptoms. But that's not always true. On autopsy, they found that about 70% of people on autopsy have stones in their gallbladder. Not all of those people were symptomatic. Not even the people who had the biggest stones were all symptomatic. So we don't really know why some people are symptomatic and some people are not. We just know that that is true, but that many people are going to end up developing stones in their gallbladder by the time they die. This is a picture here of a gallbladder that's just filled with stones. And as you imagine, we call them stones, right? Well, that's what it looks like. It looks like gravel. It looks like you went out and pulled the stuff out of a driveway or something like that. It's gravel. I mean, this is stones. This stuff's hard. And that's why it hurts. It gets stuck in that tract. It gets stuck in that common bile duct, and it blocks the common bile duct. And first of all, it hurts going through there. But secondly, it also is backing things up and is going to cause pain as well. Disorders of the pancreas, pancreatitis being a very common type of disorder of the pancreas that we see. Pancreatitis is caused by inflammation. The most common reason why somebody is going to develop pancreatitis is because of biliary tract obstruction from a gallstone. So we had one of those gallstones we just talked about, and it blocked the biliary tract. Now, the biliary tract is not only draining bile down into the duodenum, but kind of off to the side, we also have the pancreas. The pancreas, one of the functions of the pancreas is to produce gastric enzymes that are used in digestion. So the pancreas is producing its gastric enzymes. Those are flowing down through the pancreatic duct, and the pancreatic duct and the common bile duct come together before they attach to the duodenum. So we looked at this picture before. Notice down at the bottom there, you see, okay, here you've got your gallbladder, and you have the gallstones are coming down through the common bile duct. Now you see right before that common bile duct there enters the duodenum. You see going off to the right, there's another little duct there. That is the pancreatic duct. So the two of them come together before they go into the duodenum. So if we have a stone, as it's illustrating there, that's blocking the common bile duct and the pancreatic duct right before they enter into the abdomen, into the duodenum, that patient is going to have a backup of pancreatic enzymes. So that is one of the common reasons why a patient may have pancreatitis. Another common reason is because of alcohol ingestion. And here's what happens with the ingestion of alcohol. We ingest alcohol. Alcohol stimulates the pancreas to produce gastric enzymes. Now, that's okay if we're just ingesting a small amount of alcohol. So you take a drink with a meal, and that extra amount of pancreatic enzymes is helpful. Okay, it's going to help the digestive system. However, if you are drinking to excess, what's going to happen is you're going to develop so many pancreatic enzymes that they can't be used for digestion. They're going to start to back up into the pancreas and start to digest the pancreas. That's what we call pancreatitis. Acute pancreatitis is just that digestion of the pancreas. However, those enzymes start eating through the wall of the pancreas, getting out into the abdomen, and we call that chronic pancreatitis. And then we get inflammation not only of the pancreas, but also of the area around the pancreas. One of the diagnostic tests we're going to look for in pancreatitis is looking for an increased serum amylase and lipase levels. This is a picture here of a patient who has chronic pancreatitis. Notice that pancreas doesn't look anything like a pancreas anymore. Okay, that pancreas is all chewed up. It's supposed to have a different kind of a shape. It doesn't even look like a pancreas. The other thing it's pointing to there, it's got a little H pointing to this area. Now that was an area of hemorrhage, an area that was bleeding. The pancreas is a very vascular organ, and as those digestive enzymes start to eat through it, it's going to eat through the outside wall. Pancreas is going to start to bleed. The patient ends up dying of either hemorrhagic shock, because they're bleeding from those hemorrhagic areas, or of septic shock because the patient develops this overwhelming out-of-control inflammatory response, what we call the systemic inflammatory response syndrome. GI cancers are another condition we have to be aware of. They can happen many different places in the GI tract. We can have esophageal cancer. We can have stomach cancer. Those two are more common with people who have an excessive intake of alcohol. We can have colon and rectum cancers. Okay, and again, the only way we usually know the patient has colorectal cancer is by having some kind of GI bleeding. Liver cancer is fairly rare as a primary tumor. However, the patient can have a primary liver cancer, and again, we may not notice that until the patient develops some jaundice, which would be very advanced disease. Gallbladder cancer or pancreatic cancer can occur as well. So this is just showing some of the different things that can happen here with cancer in the different areas. In our colon cancer, for example, so about 45% of our colon cancer is going to be in the rectum, 15% in the descending, 15% in the transverse, and 25% in the ascending colon. Let's take a look at a few more questions now. A 40-year-old male presents with epigastric pain. Tests reveal acute pancreatitis. The most likely cause of his condition is... If you answered biliary tract obstruction by gallstones, you would be correct. That is the most common cause of pancreatitis. Tissue damage in pancreatitis is caused by what? Leaked enzymes. Enzymes leaking from the pancreas, or enzymes being overproduced by the pancreas, leaking, becoming activated, causing autodigestion, inflammation, and then damage to the pancreas. A 39-year-old female presents with abdominal pain and jaundice. She is diagnosed with gallstones and undergoes cholecystectomy, and analysis of her gallstones would most likely reveal a high concentration of what? The majority of gallstones are composed of cholesterol. So remember again, cholesterol is the base here of gallstones. Renal stones, on the other hand, are usually calcium-based, but gallstones are usually based in cholesterol. A primary cause, or the primary causes of duodenal ulcers include, select all of them that apply. Answers are B and C. Infection with H. pylori and chronic use of nonsteroidal anti-inflammatories are the major causes of duodenal ulcers. The other answers do not commonly lead to duodenal ulcer disease. Well, thank you for joining me for Alterations in Digestive Function. This is David Woodruff, and until next time, bye now.